Durant Technical Panel on COVID-19 response in low-resourced settings. I want to welcome our panel and discussants, and to the broader global health community. We have about 75 people on the line joining us. My name is Louise Ivers. I'm an infectious diseases physician at Massachusetts General Hospital, and I'm the executive director of our Center for Global Health here. Mass General Hospital is a Harvard teaching hospital. We all here are gathered on the line today because we're having the highest level of concern for the impact that this pandemic will have in regions and communities and health systems that are already often working over capacity and that often have very limited access to resources. We're all working around the clock to prepare our communities, our own communities, our institutions for a surge in patients. This panel is coming together to discuss the unique challenges of responding to COVID-19 in low-resourced settings. Our goal today is to exchange ideas, exchange solutions in the response to this outbreak. We're hoping this conversation is the first of a series of opportunities to come together to discuss response efforts and challenges. I want you to know that this webinar is going to be recorded and we'll post it on our global health website, the link for which is in this first slide. Next slide. So I want to welcome many colleagues and partners on the line. This is just a handful of you. I'm not going to introduce everyone, it'll take us all day, but thanks for being here. We'd like your engagement in the session. Some of you have submitted questions in advance. We have used those questions to guide our discussion points, and we'd also encourage you to submit further questions throughout the discussion using the chat feature. We have colleagues here in the room with us who are going to be trying to catalog those questions. We'll answer as many of them as we can here, and then we'll try to find other ways to follow up after that. If you can move to the next slide. I'd like to introduce the panelists. I'll do that very briefly because I don't want to take all the time. I want to hear from everyone. We have Dr. Lindsay Baden, who's Director of Clinical Research at Brigham and Women's Hospital. He's Deputy Editor of the New England Journal of Medicine. We are due to have Dr. Larry Ronan, who's the Director of Durant Fellowship in Refugee Medicine. He is delayed, but hopes to join us later. We have Dr. Vanessa Kerry, who's the CEO of Seed Global Health. Dr. David Walton, who's the President and CEO of Build Health International. Dr. Peggy Lai, who's a pulmonary and critical care physician at Mass General Hospital. All of those doctors are also faculty at Harvard Medical School. We have a colleague, Dr. Maxi Raymonville, who's the Executive Director of University Hospital Mirebalais, Haiti, joining us, and Dr. Kajumbura, who's a virologist at Makerere University and part of Uganda's National Task Force. So what I'm going to do is just also, to the next slide, let you know for the agenda for this meeting. We're going to start off with some prepared comments from our panelists on some key thematic areas. Then we're going to have a discussion which I will moderate based on some of the previously submitted questions. And then we will do our very best to discuss the questions that you are submitting live to us through the chat function. So with that, I'm going to pass it over. The QA feature, I'm sorry, it's the QA feature. So to submit your questions. So I'm going to pass it over to Dr. Lindsay Baden first to give us a summary of the science. Thanks, Dr. Baden.
So I've been asked to give a quick update on how did we get here and some of what we know and what we don't know. Next slide, please. As we all know, back in December of 2019, which seems like eons ago, but really was less than 12 weeks ago, Wuhan pneumonia, or this respiratory illness in Wuhan, China, was being observed by many of the providers there with an unclear etiology. Next slide. On January 24th, 8 weeks ago or less, there were a series of publications in the New England Journal of Medicine and in the Lancet characterizing a novel virus that had been identified as associated with this pneumonia that was spreading. And the sequences, as noted on the right, were obtained from multiple patients showing largely identical sequences, suggesting transmission was ongoing. This all derived from a respiratory type of illness, as illustrated in the chest X-ray. Next slide. In the Lancet, the two articles on January 24th demonstrated features of this illness, which was a respiratory illness, as well as transmission occurring in family clusters. Next slide. And a week later, on January 29th, published in the New England Journal, are the first 425 known cases. And what this image shows, the dark orange small bars on the left of the slide are those infections associated, thank you, with the wet market. And then the light orange, which is the subsequent 2 weeks, are those infections not associated with the wet market, suggesting that community spread may be going on. And these observations are over 2 to 3 weeks. What's also notable, circled in red, was that the Chinese CDC stood up diagnostic testing within a week of the sequence of this virus being known. Next slide. Back one. This image from the WHO from about a month ago at a meeting, a summit they had in Geneva, shows the state of the understanding as of a month ago. January 7th, circled in red, the coronavirus was identified. January 12th, circled in red, shows when data were presented to WHO of this novel virus emerging. And January 23rd, circled in red, is one of the control measures that were implemented in China, which was shutting down of a city of 17 million, given the speed with which the transmission was ongoing. In red are many country names showing when the virus was identified in multiple countries over the course of January to early February, indicating the speed with which this was spreading globally. Next slide. A challenge in this illness is, what is the illness? Currently, there are over 120,000 cases that have been confirmed. 14% of them develop severe disease, developing hypoxemia, and therefore 5% need ICU level support, 2% mechanical ventilation, and the CFR case fatality ratio has been estimated in the 1 to 3% range. What's challenging about interpreting these data, as illustrated in the image in the upper right, are those individuals who are testing, are the individuals who are sick and presenting for care. We are not testing because we don't have capacity, infrastructure, and it's not the same priority. Those who are in the community who may be ill, such as children or those with minor illnesses. Therefore, the spectrum of minor illness is not well characterized, but many of us suspect this is going on, as evidenced by the news reports of transmission rapidly across the globe and many countries in Europe and across the US. The individuals at high risk for complications seem to be those who are older, and from the data from China, they suggest it's greater than 60 years, maybe 70 or 80, maybe at higher risk. Those with comorbid illness, particularly cardiopulmonary disease, higher SOFA or acute injury scores, and some laboratory parameters such as LDH or D-dimer. The complications are associated with a respiratory virus, which are largely pneumonic. The lungs get infected and impaired, ARDS, sepsis, and other systemic injury occurs. We have very, very little data on children, pregnant women, and many other important populations. Next slide. The clinical manifestations, as reported about 10 days ago, from the first 1,099 hospital, or this was 1,100 of the first 8,000 hospitalized in China. So these are the more severely ill who are hospitalized. Fever, cough, lymphopenia were the common features. Some had sputum production. Early on, diarrhea was important, but does not seem to have persisted. And notably, 44% of those who were more severely ill subsequently presented to hospital with only half of them having fever or half not having fever. The image on the right of this slide, which can be seen in the published article, shows the laundry list of symptoms that were assessed to be able to determine which of these symptoms may contribute to the presentation. The radiology, in about half with GGOs or ground glass opacities or evidence of a viral, a pneumonia, or lung injury, though some had no abnormalities. Next slide. This image are typical images of the lung injury. The top row, A, B, and E, are the chest X-ray and chest CT scans of a mild to moderate illness individual. And the lower is one with more severe lung injury. Normal lung should look black. The hazy white strands in that black part of the lung suggests the injury, which is a diffuse GGO or ground glass opacity type of pattern, which can progress to severe disease. Next slide. The clinical evolution of these cases are still being defined. From the first case, which occurred in the United States, the individual, or that was identified in the United States, was an individual who had some respiratory symptoms and approximately around day 10 of illness developed hypoxemia and progressive lung injury, suggesting that there may be phases to this illness as lung injury emerges, given the nature of the viral infection and the disease it causes. However, the clinical evolution of these cases and the role of superinfection still needs to be defined. Next slide. Transmission, which is what we are witnessing, as we have only known about this virus for a little over 2 months, yet it is clearly globally spread. When does infectiousness start? When does infectiousness end? These are very challenging to determine. What has been shown in small case series and individual cases are that some individuals, when they are pre-symptomatic or asymptomatic, can have culturable virus identified in their oropharynx and nasal secretions, suggesting that transmissibility may occur prior to symptom onset, or in those individuals who may never develop symptoms. In those individuals who are diagnosed with this illness and then followed, persistence of nasopharyngeal positivity by PCR seems to be about 20 days. We do not know if the virus is still culturable and transmissible towards the latter part of illness in those who recover, but persistence of the nucleic acid raises concern for this to be properly identified. In some settings, such as this report in JAMA in China, nosocomial transmission was significant, and therefore it is very important that protective equipment such as masks, gloves, and appropriate hand cleansers and environmental cleansers are available to diminish the risk to healthcare workers and to subsequent patients that we care for. Next slide. Treatment, there is no known specific treatment other than we give supportive care, oxygen, fluids, whether superinfection is important, such as bacterial, fungal, or otherwise, needs to be monitored and addressed. The role of agents to diminish the inflammatory state, such as corticosteroids or more targeted blockers, remains to be defined. There are off-the-shelf agents that are being looked at as potentially having activity, such as Kaletra, lopinavir, ritonavir, chloroquine, penciclovir, ribavirin. The role of ACE inhibitors or ARBs as the target binding receptor is the ACE2 receptor. So there are those who are looking at whether or not this can be interfered with to prevent disease. And then a variety of experimental medications that are being looked at. So I'd like to thank you all for your attention. That is a brief overview of how we got here and many of the questions that we face as a community in responding to this event. Thank you for your attention.
Thanks, Dr. Baden. Thanks a lot. We got a question about that I'd love to pose to you right now is, what do we know about the disease in HIV affected communities? And do we know anything about that?
So I think a very important question of what is the intersection of this illness in those who are vulnerable or with other illnesses such as HIV or tuberculosis, and we do not know. It does not appear to be worse in those with HIV. However, I think the data are too early and inadequate to make a strong conclusion, but there is not an early signal in HIV. There is not an early signal in pregnancy. There is not an early signal in pediatrics. But those are all very important questions that we have to be mindful of and pay attention to.
Thanks very much. Really appreciate your comment. we're gonna we're gonna pass over to Dr. David Walton now to give us some comments. Thanks, Dr. Walton.
Thanks so much, Dr. Sorry. All right. Thank you so much, Dr. Ivers. I'm going to spend a little bit of time just talking about general IPC principles. And I'd like to thank Dr. Baden, who we all sort of look up to as a teacher and a mentor here, and appreciate his contribution. And I want to contextualize my comments by saying that I think the challenge in trying to be pragmatic is understanding the recommendations around IPC and then understanding the constraints that many of you are working in. And so I'll try to address both during my brief commentary, and then hopefully there'll be some questions at the end. But again, as Dr. Baden noted, really IPC, when we think about IPC, we're thinking about the vectors and how it's transmitted, and particularly with this disease, it's droplet nuclei as well as transmission, we think, with fomites. And so to that end, the recommendations by the CDC and others have been pretty clear as a healthcare provider, and that's what I really want to try to focus on today, which is what is the PPE that you need. First of all, again, there's been a lot of photos in the media around people with sort of Ebola-style PPE that actually isn't necessary. Let me go through step by step what is necessary and what is recommended. Eye protection, making sure that your eyes are, and sort of not just your eyeglasses, but either a face shield or goggles that have sort of protection from the lateral aspect to make sure that no droplet nuclei can enter into the mucous membranes of your eye. Secondly is a gown. The gown is can be a disposable gown, or it can be a cloth gown that would obviously have to be laundered and sort of specially taken care of, given the transmissibility, given that you're not disposing of it. Thirdly, gloves. And these would be regular gloves that you would use in the examination of any patient. Again, contrasting to Ebola, sometimes there was very sort of elbow-high gloves. That is not necessary, just regular gloves are important. And then I think what is somewhat, not quite controversial, but particularly sort of a topic that causes some anxiety is how do you protect yourself vis-a-vis airborne or the droplet nuclei? And the recommendation is the N95 mask. Now, the N95 mask is tricky, right? Some of us have access to it. Even in the Mass General Hospital or other Harvard teaching hospitals, we are running out. And so there's been a series of protocols to try to ration those masks. But the other specific idiosyncrasy of N95s is that they come in different sizes. And in order to be assured that the N95 is providing protection, you have to be fit tested, which is a whole process in and of itself. And if you're not fit tested and using an N95, you may or may not be protected. I, for example, went through fit testing at my hospital, the Brigham Women's Hospital, earlier this week. And unfortunately, my facial hair prevents me from using an N95, so I have to use a PAPR, or a sort of powered by a purifying respirator that sort of covers my head, et cetera, and has positive pressure. And so again, those are probably scarce, if not available at all, in resource-constrained settings. And so what do you do if you have a limited supply of N95s, or you have no N95s or no respirators? And I'll touch on that in a moment. And then my final point before I talk about sort of the scarcity of supplies is, how do you think about donning and doffing? Again, critically important. And there's instructional videos that are available both from Massachusetts General Hospital, where we're sitting, and others. But the donning and doffing is critical because, again, like many other diseases that are transmissible, making sure that you're donned correctly or your PPE is put on correctly is critical to your protection. But what is also really, really important is that your biggest risk of transmitting the virus to yourself is at the doffing stage. And so doffing is critical because, again, let's assume that you've donned properly and you have examined the patient in a room or a ward in which there are droplet nuclei or fomites. Now you are covered, potentially. And so you really need to exercise an extreme amount of caution and follow the protocols that your institution or others have sort of called for in the doffing procedure. And then, again, I think it's critically important to be pragmatic around PPE, and what do we do when we have a scarcity of PPE, which much of the world is going to face, if not now, very, very soon. Let's talk about N95s. N95s are ideal, but if you don't have them, the recommendations are surgical masks will offer some protection. It's not going to offer full protection. You're obviously not dealing with a fit tested N95, but that is the recommended sort of surrogate if you don't have an N95. And then again, even if you have surgical masks and you have a large number of patients that you're seeing, what if you're going to run out and you can't actually get more supplies? There is a position paper about reuse by the Association of Infection Prevention and Control, circa 2009, that does allow for some protocols around the reuse of masks in particular. And some of the tenets of that, you can sort of search for it on the tenets of that are extended use over reuse. So sort of keeping your mask on as long as possible if you can, as opposed to trying to reuse it. But you can reuse it. Ideally, it's a single user will reuse their own mask, not someone else's mask, putting it in a specialized location so it doesn't lead to the contamination of other spaces. And ideally, limiting that reuse to one shift. And so those are some pragmatic ways that I think are helpful in order to try to conserve the supplies that are going to either are currently scarce or are going to be increasingly scarce as this pandemic sort of continues. And then I think, I'm going to wrap up here with probably the thorniest issue, which is in settings of resource scarcity, how do you deal with sort of triage and patient flow? And we've been thinking about this a lot here at the Center for Global Health at MGH, and there isn't a right answer. I haven't seen, Dr. Ivers hasn't seen, and others haven't seen necessarily recommendations. But I think we're currently sort of thinking through some protocols, but we're thinking of them as we sort of taking lessons from Ebola and cholera in terms of really segregating an entire space of the hospital that is completely separate, or tents outside for the COVID suspected patients. Dr. Baden said something actually critically important that's going to be a challenge as we move forward, which is half of the patients in that retrospective study that he was talking about didn't present with fever and yet tested positive for the virus. So as we think about segregating patients right before they enter your facility, sort of go right for if you're a COVID suspect, go left if you are just there for a bellyache. How do you do you have testing? Testing's another tricky issue that we'll talk about later. But if you don't have testing and you're going through sort of clinical criteria that many used during Ebola and cholera, what does that clinical criteria look like, given that the predominant symptoms are fever and cough, and half of those patients aren't presenting with fever? So this is an ongoing topic of discussion and a significant challenge. And then my final point is, if you do have a space in your hospital that is segregated, here we put all of our patients in sort of respiratory isolation rooms with negative pressure, 12 air changes per hour. Again, that's ideal if you have it. If you don't, and you do have private rooms, that's perfect. If you do, with the door closed, you don't necessarily need negative pressure. And again, if you don't have single rooms, then again, we're thinking through how do you segregate patients that may be suspect, but not sort of engage in nosocomial spread from one patient to the next. So those are topics that we'll be thinking through. It's a really tricky scenario, especially in spaces that are limited, but I'm going to wrap up my comments now and transition over to, sorry.
So thanks, Dr. Walton. We have a question.
Yes.
And I wonder if you could try to help us address that. What if you are not just in a situation of scarcity of N95 or other masks? What if you don't have them at all? And I also wonder if you could comment on potential strategies in the workforce of using people, health workers or volunteers who are survivors who have recovered from COVID-19 as we look down the line in weeks and months from now. Thanks.
That's a great question. Thanks, Dr. Ivers. And you know, I don't have an answer to if you don't have masks. I think, you know, if you don't have a mask, you sort of go in with the understanding that given the transmission dynamics that we understand to date, that there is an extremely high chance that healthcare providers, or you as a healthcare provider, are going to contract the virus. And again, when we look at these diseases, Ebola, et cetera, you know, we really want hospitals and care facilities to be places where people are both the healthcare providers and the patients are protected. So that's a really tough one, and I wish I had an answer. Maybe others on the panel or those in the audience may have some ideas. In terms of sort of taking a page out of the Ebola handbook and using survivors as frontline workers, particularly potentially with the task shifting, again, potentially in this setting of scarcity of supplies. It's a great question, and you know, unfortunately, I think Dr. Baden isn't on the line, but it's a great question. I don't know if we know enough about sort of the virus to know that those who recover cannot be reinfected, and or when they stop transmitting the virus. But it is an interesting thing to continue to think about in terms of if, say, viral shedding stops and survivors cannot get reinfected and they have some level of immunity, can we leverage them, as we did in the Ebola epidemic, to sort of be part of the workforce of the frontline health providers? And so I think that's a topic to continue to sort of investigate as we understand more about the virus itself.
Thank you very much, Dr. Walton. Really appreciate that. I wanted to emphasize, I think, as we see questions coming in and as we ourselves try to deal with this outbreak, we're learning so much as we go. We're going to try to very much keep on top of the science around some of these questions that are coming in. We did receive a question about using ACE inhibitors. I think ACE inhibitors, again, we don't have any evidence yet. They may actually upregulate the ACE receptor, and so they may be harmful. We don't know. So I think there's no evidence, as Dr. Baden has said, at this time on specific interventions, but we're keeping our eyes on all of that. I think our next speaker is going to be Dr. Peggy Lai. I'll hand it over to you, Dr. Lai. Thank you.
All right, can everyone hear me okay? Louise, can you hear me? Can you hear me? Yep, okay, great, all right. So I was asked to comment on sort of a low resource critical care and also oxygen shortage and allocation. I will just preface this by saying that one caveat is that we have just started to get critically ill patients with COVID-19 in our ICUs right now. So I'm gonna try and summarize based on the literature. I did have a few slides. I don't know if, Kerry, you can put that up or not.
Did you send?
Yeah, Kerry, I sent it to you.
Great. I'll get those.
While we're getting it up, I can also just sort of start talking because I know there are a few other speakers and obviously there's going to be time for discussion. And so, you know, when I was thinking about this problem, I think you have to break it down to a few categories. And so one major issue is that there are actually a lot of high-risk activities for healthcare workers in the context of critical care. And the second is that, you know, unfortunately, in most resource-limited settings, even if you have an ICU, it's a giant sort of room and not individual patient rooms. And finally, this big issue of sort of resource constraint and allocation. Can you click next? So in terms of high-risk activities, so, you know, it's pretty clear that, you know, certain activities like intubation, for example, or bag mask ventilation, bronchoscopy and suctioning are actually very high-risk sort of procedures for healthcare workers involved. And there is some data, if we're trying to extrapolate from the SARS epidemic, that, you know, even certain therapies we have, such as BiPAP or non-invasive ventilation, also has a pretty high risk of aerosolizing the virus. And so, you know, again, we're trying to figure out what best to do, but, you know, if you're performing a high-risk activity, only do it if it's absolutely necessary. Try and minimize the personnel involved. And if you have a limited supply of, say, N95s, try and sort of prioritize these masks for the people performing these high-risk activities. I'll also say that, in a lot of contexts, some ICUs in resource-limited settings might have ventilators, but they might not have all the things necessary, such as HEPA air filters to filter out the exhaust from a ventilator. And so these things need to be carefully thought about. The next issue that I wanted to bring up is the lack of individual ICU patient rooms. Can you click next on the slide, please? There's really no guidelines right now, and so trying to extrapolate again from sort of WHO recommendations is trying to have a 6 feet distance between individual patients, and then trying to clean high-touch areas with frequency using something like 0.1% bleach, 70% ethanol, or any of the other sort of recommended disinfectants. And then I think the hardest question I was asked to address is the issue of resource constraint and allocation, especially in the context of limited oxygen supplies, for example, or limited ventilators. Can you click next, please? I don't really have a good answer for this because this is very difficult. I will say that when I work with colleagues in resource limited settings, it's a challenge that they have to face every single day. This is outside of the context of COVID-19. I think it might be helpful to sit down sort of with all stakeholders, whether it's within your physician group, with your leadership, and come up with some consensus guidelines, because trying to ask each individual healthcare worker to make that decision is excruciating, and it's very difficult. And just to have compassion for those healthcare workers who have to make that decision, because it's not easy. But the truth is that if you don't make a decision now, by not making a decision, you are making a decision when your ventilators run out, when your oxygen runs out. And so I think, really the best way to do this is to try and be prepared and have some sort of consensus amongst your healthcare providers on how best to allocate these resources. And then finally, I know we're all being barraged by a lot of data, different publications and things like that. And so can you just click next, please? I will say that, this website is actually pretty good. It's focused on critical care. It's well referenced. I've looked up every single comment that they make, and I think it's a fair interpretation of the literature. And so as things evolve and you're trying to manage sort of all this information, I think this is a pretty good aggregate website for critical care. Thanks. That's all the comments I have to make.
Thanks very much, Dr. Lai. I really appreciate it. I think you're going to be able to stay on the line with us, so we'll gather if there are any specific questions for you and come back to you shortly. Thank you. I'm going to hand over now to Dr. Vanessa Kerry to speak with us next. Thanks, Dr. Kerry.
Can you hear me now? I want to just talk about one of the challenges that we see happening in the, when we think about how we're going to respond to really what we expect to see, not just really around the world. We've seen this starkly in China with the onset of COVID. Certainly in Italy, they are struggling with this, and we're anticipating that we will see this in many countries that are very hard hit by the outbreak and pandemic. And I think that, as you know, and has been discussed, healthcare workers are really at high risk of getting infected with the virus because we are on the front lines and providing the care needed. And that can be very tricky in terms of, ensuring our own safety as we're doing some of these higher risk procedures. So I wanted to just spend a moment to kind of think just to kind of outline some of the core issues that we're up against that may be more acute in certain places in the world. If you could just go to the first slide, please. When we talk about, the WHO really has done a good job of trying to outline for us what are some of the challenges that we face, in general, if we're going to stand up a strong health system. And so, well, on the left, you see the outline of service delivery, health workforce, information, vaccine, financing, et cetera, is needed to really create improved health responsiveness and the ability to provide high quality care. If you go to the next slide, the challenge here is that there's a disproportionate burden of disease in parts of the world already, if you click again, as you know, HIV, 75% of the burden, or 97% of the burden of HIV is in lower and middle income countries. Non-communicable disease, the next one, 80% of non-communicable disease deaths are happening in low middle income countries around the world. And if you go to the next slide, 99% of maternal mortality is happening in low middle income countries around the world. So we have an issue that as we're looking at this new pandemic that is bringing a new surge of disease, it is very problematic, not only in countries where there is maybe a better compensation of addressing disease burden, but that it's going to be overwhelming potentially in places where there's already very high levels of disease burden. If you go to the next slide. When you look at the geographic distribution of the global burden of disease around the world, as you can see, Sub-Saharan Africa is about 25% of the global burden of disease, and Southeast Asia has roughly 40%. So we're dealing with, 30%. So we're dealing with also unequal distributions. The problem with this pie chart, if you go to the next one, is that there's an unequal distribution of the healthcare workforce. This is statistics you all know, but it's simply to highlight that the burdens of disease are worst in the places where there's the least amount of workforce. And if you go to the next, worldmapper.com just does a good job where the human resources for health resources are most concentrated. So if you go to the next slide, these are doctors. If you go to the next slide, anesthesiologists, which are critical also in providing critical care and staffing some of the ICUs. And if you go to the next slide, just to give a sense of the density of surgeons, anesthesia, and OB that we see. As we know, there is data that shows that the higher the healthcare density of healthcare workers, the higher the survival. This was really chronicled in 2006 primarily, but that has been a growing statistic, which has changed the emphasis on trying to address healthcare workforce shortages globally. And if you go to the next slide, we talked about this already, so I won't spend much time on it, but if you click again, some of the data that is coming out of China and increasingly elsewhere has really started to highlight what are the presenting symptoms or the progression of COVID beyond what we call mild illness, which we believe affects about 80% of the population. But when it does advance to more severe disease, we know that it advanced primarily into respiratory distress, specifically acute respiratory distress syndrome, or ARDS. This graph is the data that comes out of the China study that looked at a cohort of patients in a Chinese hospital and looked at the patterns of disease. This came out in JAMA, and the citations on the bottom, it's worth taking a look at. Sorry, the New England Journal of Medicine. It's worth taking a look at just to get a sense of the pattern of disease, and we can help make that available if that is helpful. But importantly, just when we think about what are the kind of staffing needs that we might need specifically to address this, we know that pulmonary and critical care needs are going to be important, in addition to just general frontline management of the various pieces of fever or respiratory distress. If you go to the next slide, this is another cohort that came out recently. This is about 2 days ago in Lancet, that looked at the clinical course and risk factors for mortality in adult patients with COVID-19 in Wuhan. And it was a retrospective cohort study. In this study, this was done at a respiratory hospital. And interestingly, they show slightly different data than what came out in that original New England Journal article. Of the patients that there's about 191 patients that they looked at here. 54 died in hospital, which is a much higher rate, but they also had half those patients had some kind of comorbidity. And again, if you look here at the prevalence, here you're now looking at higher rates of sepsis, respiratory failure, ARDS, heart failure is increasingly an issue. We're realizing septic shock. So again, when we think about what is the kind of specialty and healthcare workforce we're going to need to respond this and the skill set, we need to be thinking about how do we ensure that we have the skill sets around managing acute respiratory disease and sort of the physiology of sepsis and cardiac collapse. When we look at ICU preparedness around the world on a more global level than just sort of some of the, actual acute needs in an ICU, there's very little literature on ICU capacity globally. And there was a 2015 review on lower income countries that really yielded only 15 studies with data that was usable to really understand and characterize what the ICU beds were. And really, there was only about 22 ICUs really provide data on mechanical ventilation needs, and only about 75% of ICUs that were chronicled in the study do have mechanical ventilation, but it's usually only 1 or 2 ventilators. If you go to the next slide. Sorry, we're through a couple slides. I should have kept pushing you. Next slide. This is just to give you a sense of some of the ICU data that we do have from around the world. So depending on what country you're in, you have a different capacity. This data is from 2012, so it is a little bit older. But importantly, as you can see, many countries have a limited number of ICUs in total and an even limited number of ICU beds per population. So this is going to present very real challenges about how we triage and manage patients and what is available to be able to manage those acutely ill patients. And I think that when we think about, if you go to the next slide, there's additional challenges just beyond the beds. I visited hospitals in some of our partner countries where I've seen well-equipped ICUs with beds, with monitors, but there's no staff to actually be able to run those facilities. There's certainly nursing shortages that will be an issue. We know in terms of nurses who are trained to manage monitoring or to be able to, work in the critical care setting. And certainly because of nursing shortages, the patient to nursing ratio is difficult. And that can often put pressure on families to provide care. And when we think about worrying about who's appropriate to be managing a severely ill or acutely ill COVID patient when they're at their most infectious, it's very difficult when we think about disease control, how you rely on untrained, family or other support to help care for these patients. And so I think that workforce issues are going to be really an issue in many settings. If you go to the next slide, you can actually skip that one, please, and keep going. The other trick here is that even if we are issuing best practices to help guide our colleagues in places around the world, we know that there are gaps in best practices and protocols in many settings that don't have robust ICUs scaled up already. And so that bundles and protocols that are available are often developed in resource-rich countries, and they may not always be adaptable to resource-limited settings. And so we've seen this in sepsis guidelines, for example, where many of the bacteria that we worry about that might be more prevalent in, say, sub-Saharan Africa are not often included in guidelines for sepsis management. Next slide. So there are some guidelines that have been issued and tried to be, and have tried to be tailored. And I think this is a question for all of us is how do we build kind of a coalition of people who can work together to create what these guidelines should be in COVID and to help provide some of those answers, because they're going to be difficult to develop in the acute setting. Whereas if we are in a moment of sort of calm before the storm, which some countries are right now, this is the time to be thinking about how you're going to make those decisions so that you don't have to figure out how to make those decisions in real time when you're also confronting significant disease. For the sake of time, I will skip the early resuscitation study in Zambia. You can go forward, please, several slides. Keep going, keep going, keep going. That was just an example of how basically a bundle was applied in Zambia in the setting of sepsis and actually led to increased mortality, because giving a high level of fluids when you can't actually always monitor clearly for worsening respiratory distress led to worse outcomes. The approach to ARDS will be very important in this, and importantly, incidence and outcome ARDS has not been reported in low-income countries necessarily. And I think that one of the tools we can give our colleagues who are going to be addressing this is how do you use non-invasive methods to evaluate for ARDS or worsening consequences. And there have been, if you click again, The Berlin definition relies on invasive intubation. If you could click again. And so we're probably have not been estimating ARDS appropriately in all countries. And if you click again all the way through the slide, it's simply to say there are validated non-invasive methods that can be used. And I would refer you to Riviello et al., who have published on this about using just oxygen saturation monitors, ultrasound, and modified definitions. And if you click again to the next slide, click 3 times so you get all 3 columns up. If you just look at column 3, the Kigali modification of Berlin can be helpful when you're starting to classify and stratify patients with ARDS. And so I will just stop there for the sake of time, but it is simply to say that we are going to have a shortage of people who have the bell curve of experience with some of these, severe aspects of illness, of disease. And there's also a lot of talent in these countries. So it's going to be on us to figure out how do we really expand those that do have that experience into protocols and algorithms that can guide others who maybe don't have that experience, and to help expand that knowledge for managing this disease in these places. Thank you.
Thank you, Dr. Kerry. Can I ask you to address a question to follow up on some of the comments you made? Specifically, we've had some questions about workforce strategies that would help to keep clinicians being able to come to work in terms of policies around paid sick leave, caring for others. Have you been thinking about, or any ideas about strategies that governments or non-governmental organizations might use to try to keep their workforce stream available?
This is a terrific question. And I think that as we think about our preparedness and workforce shortages, and we are going to be confronting this in every setting. So we're definitely united as a workforce, and as those of us who work in the health sector, to be thinking about these kinds of policies. And it's a critically important question to be thinking about. So I don't have a perfect answer, because I think that we are, the challenges are going to be, how do we take care of all the patients and at the same time maintain mental health and care for those that are ill in our family. I think to the degree that we can, it's going to be incredibly important for us to think about how we create paid sick leave. We make that possible for people, because the loss of income is, if you are sick when you got ill, working in this epidemic setting, I think will be very demoralizing, and you run the risk of actually losing that workforce person to not return at all after they do recover. And I think one of the things that we know is that we're going to need everybody to help support the response here. And so making very proactive investments in the well-being of the workforce through paid sick leave or paid family leave, if they need to leave to take care of someone sick in the family, well, it's going to be critical to ensuring that they return and continue to work to fill this. So I think that's going to be important. Equally, I think we're going to have to think very carefully how we address what happens if schools close in these settings and people are confronted with the fact that they have to deal with childcare. And I think we're going to have to be very supportive in those settings as well. Our ability to respond to this pandemic appropriately is entirely going to lie not only in our individual actions of social distancing and our individual actions to take every precaution in the clinical setting as we provide care, but it's absolutely linked to governments making progressive, smart policies that protect their population and protect their healthcare workforce and invest in the well-being, the mental health, and the value that we all bring as we engage with this. And so governments are essential to how we're going to address this. And I think that we have to think as a global community proactively how we create those policies for best practice to both advocate for and to guide governments to make the right decision, because that's going to be essential. So it's a terrific question.
Great, thanks very much, Dr. Kerry. Appreciate that. I'm going to take a couple of questions before we next turn over to Maxi Raymonville. But first, we had a question about chloroquine. Chloroquine did appear to have some activity, but it is under investigation. There's no evidence right now that it could be used as a treatment, but there are some folks studying it. Dr. Lai, I think you're still on the line with us. I see you there. I wonder if you could take a couple of questions which I'm bundling together, which is really about rationing of oxygen, rationing of medications and antibiotics. From your perspective, I mean, obviously none of us ever want to ration, but we're often faced with that situation. Are there oxygen levels? Is there any way for us and those of us on the phone to try to guide the care of our patients in terms of hypoxemia? What level could we tolerate? Any guidance for us? Thanks.
Yeah, I think we can, extrapolate from the clinical trials in acute respiratory distress syndrome, or ARDS. And so, in this syndrome, what we do is we accept oxygen saturations of 88% or higher. So you don't need to aim for 100%. In fact, you may not need to. And so I think it's safe to say that, if you aim for oxygen saturation of 88%, that's reasonable. In fact, it is the accepted sort of standard of care. In terms of medication shortages, I think, one thing to highlight is that obviously COVID-19 does not need to be treated with antibacterials if it's clear that there's no superimposed bacterial infection. And, one useful strategy if procalcitonin testing is available in your hospital is that, if someone comes in with COVID-19, their procalcitonin levels are not elevated, it's a reasonable strategy to just discontinue antibiotics and conserve it for people who really do need it. But I think it does sort of need thoughtful thinking about, which therapy is going to actually be helpful for your patients.
Thank you very much. I want to turn the microphone over to Dr. Maxi Raymonville, who is an obstetrician gynecologist and the executive director of the largest teaching hospital in Haiti, Mirebalais Hospital. Dr. Maxi, could you give us an update on your situation in central Haiti and how you're preparing for coronavirus? Thanks.
Thank you, Dr. Ivers, and good morning to everyone. I'm sitting right now in the Mirebalais Hospital. And Mirebalais Hospital is one of the 5 teaching hospitals in Haiti. In Port-au-Prince, we are talking about 2 teaching hospitals, one in Carhaïtien and in the center of Haiti. And we have Mirebalais. Mirebalais is not only providing services, but we are training physicians as surgeon, OB/GYN, internists, urgentists, and a pediatrician. Right now, there are 125 physicians on trainings and 6 to 10 nurses to become nurse anesthesiologists. As you can understand, it's really difficult, to bring physician anesthesiologists in a limited setting, resource area like in Mirebalais. But the situation in Haiti right now, it's the Ministry of Health did not report any case for Haiti, but for Dominican Republic, they are reporting at least 5 cases. Only this morning, they are talking about maybe 2 additional cases, but I'm not sure. But speaking in terms of Dominican Republic and Haiti, looking at the border, it's really difficult to manage this coming back and Haitian illegal Haitian, trying to cross the border in terms of work. And not only that, if you Dominican cross the border, in terms of helping to the workforce in Haiti, it's really difficult, to manage this situation at the border level. And right now, what we are sitting with the Ministry of Health in a meeting. Dr. Ternier was leading all of these activities for Zanmi Lasante. Zanmi Lasante, this is the same translation for PIH, Partners in Health, but Partners in Health is based in the state, supporting most of their activities in Haiti. But the Ministry of Health is one of the privileged partners, and they are starting, not only to put in place the surveillance system to the national lab and the Department of Epidemiology, that's we call it DEL, Department of Epidemiology, the Laboratoire de Recherche in Haiti. And they are looking at on the surveillance right now, and they divided the strategy in terms of pre-epidemic and epidemic. And right now, because we did not report any cases, they are talking about this pre-epidemic phase. But today they are planning, to put out what they really call it the national strategy in terms of emergency preparedness. Secondly, if you look at the situation right now in the hospital, it's really difficult, to know exactly where's the space we are going to use as the isolation place. Even we have our critical care unit or ICU with 8 to 10 beds and 1 isolation room. And then there is another place in the hospital where we manage all of our isolated patients for tuberculosis and any kind of contagious and infectious disease, where we can handle around 12 patients with isolated room, with mural oxygen, with negative pressure and UV light. But right now, we cannot think how to put the patient with COVID-19 to the same place, and we are thinking to use the all structure that we call our cholera treatment center before, and we moved this name, to call a center of direct disease instead of to cholera, because we receive, it's not too many cases these days. It's really rare, to find cholera cases, and that's the place we are in place to transform as an isolation room. But the problem that we are facing in this place, it's a common place. It's not individual rooms for 10 beds without mural oxygen. We have the mural oxygen with all of these services at the main hospital. But if we are going to use or isolate or place for the all cholera treatment center for the isolate place, we'll have to think about how to rethink this infrastructure. Mostly the problem that we are going to face it's to get better understanding of the secret of this patient. Are we going to use our emergency department as the entry door? Are we going to put, another tent outside of the entry? That's mostly people that are talking about, we needed to have a place with the outside of the emergency department. And in terms
Dr. Maxi, Dr. Raymonville, thanks. I apologize for interrupting, but I thought that was a particularly interesting point that I know you and I have discussed with others in terms of how to triage at a large scale level from the public health perspective. Have you considered in Haiti having some of the facilities be specifically for caring for respiratory illness patients and kind of preserving, so to speak, other facilities for those who are not suspect cases? Especially I'm always thinking about the pregnant women and other patients who you want to provide emergency service to. Have you talked about that kind of system?
But exactly, that's the situation we are facing right now, because right now you are dealing with not only the woman's health, you are dealing with the surgery, you are dealing with the pediatric, and how you can make the division, to keep running, your main infrastructure and the isolation room. And that's right now the challenge we are facing in terms of identify the real infrastructure, adapted to that. In the main building, in the infrastructure, you have mural oxygen, you have a big concentrator of oxygen, but how you are going to bring oxygen, how you are going to use cylinders, oxygen, bonbon, what we call the bonbon oxygen in Haiti, to use in this place. But in terms of staffing, that's the same problem, all of this limited resource setting space again, and supplies, equipment in shortage is going to be really challenging,
Yeah, thanks, Dr. Raymonville, for sharing both your preparedness, and I know you've been working around the clock for the last number of weeks to prepare, and I think many of the folks on the phone are in similar situations to you and challenges. We had tried to have, or we're lucky to have, Dr. Henry Kajumbura from the Ugandan Ministry of Health on the panelist group. We've been having challenges with his audio, but I'm going to try to see if I can speak with him via Dr. Kerry, who has him on her phone line. I'd love to hear from you from Uganda's perspective in terms of preparedness. I know there are 0 cases in Haiti or in Uganda as of my last check. Dr. Kajumbura, I wonder if you could also comment on, in addition to just some general comments, what advice are you giving in Uganda to the general public about self-quarantine? I worry or think about individuals quarantining at home for mild illness. How will they manage that? How will they take care of the elderly in their community? Any comments or thoughts you'd like to share with this community? Thank you.
Dr. Kujambula, you're muted right now, it says on my phone.
Hello?
There you go. Okay, can you hear?
Yeah, thank you very much. Yes, Uganda has recognized, has declared this as a public health emergency. And on Wednesday this week, the minister actually, yes, that's when the minister declared it a public health emergency. So I hope you don't hear an echo. Am I clear?
It's, try again. Yeah, so here, I'm gonna ask you, I'm gonna have you tell me, and then I'm gonna repeat it because I think this is important. So on Wednesday, COVID-19 was declared by the Minister of Health a public health emergency in the country. Okay, I'm going to repeat. So the biggest concern is that it's obviously going to be imported into the country, and so they've categorized other countries into three. Level 1 countries are based on the current burden of disease, and they're considered highest risk.
Is not to come to Uganda.
If you shut your Zoom down, you'll be able to speak directly, yes. So he's saying that category 1 countries basically are being denied the opportunity to even come into Uganda. So countries with this burden would include obviously China, Iran, I'm presuming South Korea. I do know that in Uganda, they have just insisted that Americans traveling to the country self-quarantine for 2 weeks on arrival.
So Dr. Kerry, I think what we'd love you to do would be to...
mandatory isolation once they come in.
Wait, Dr. Kujambula, hold on please, sorry.
What I'm going to do is ask if you could have the conversation with Dr. Kajambura, and then we're just going to go to another speaker for a minute, and then we'll come back to you.
Terrific.
You can give thanks, because we definitely want to hear his
Do you
input.
want to try to hear him now though? Because he's turned his Zoom off.
We're getting a lot of feedback.
Okay,
so
we'll worry about it. Come back to us, thanks.
Okay, thanks. So thanks very much. Sorry everyone for the technical challenges there, but we're really conscious here in the Center for Global Health that we try to hear everyone's voices. And so we're extending extra effort to try to make sure we can hear from Uganda. I wanted to put a comment to Dr. Larry Ronan from Mass General Hospital, who just was able to join us. Dr. Ronan is the director of the Durant Refugee Fellowship at Mass General. Dr. Ronan, we've had a question in particular about the low reported cases from some conflict zones and from some areas where we know there are a lot of refugees. We're wondering, do you think that's related to low case detection, or are we just in early stages there, and what should we expect? I'd love to hand over to you, thanks.
Good morning, can you hear me?
Yes, we can.
Oh, good. Sorry to be late to this great conferencing. The specific answer to your question, I'd like to focus on the Middle East, and I'd actually like to turn it over to one of our participants who has on the ground information about it, Dr. Tara Rashid, who's in Iraq. But the background question you're asking is a very good one, I think, for around the Middle East, which is what is the prevalence right now, the incidence of COVID in the IDP and the refugee population, especially in Syria, Iraq, Kurdistan, Turkey, and the surrounding areas. And I'm not sure there is a great deal of data on it. The UNHCR is not reporting on it, and as of their latest communique, there was no evidence of any camp or IDP spread. But if Tara could join the discussion, I think that would be very helpful. Can I turn it over to Tara?
Yes, you can. Just 1 second. Yeah, you can go ahead and talk, Dr. Rashid.
Okay, good morning to you all. Thank you so much for hosting me. It's great to really beautiful information I heard about. Me as a member of Iraqi Red Crescent, now we are following things very carefully because we don't only have Syrian refugees in the camps, we also have Iraqi IDPs still now in camps. And all these camps have medical units there. The staff are prepared, but till now we haven't found any case so far confirmed as a case of COVID-19. But all the staff, all the members who are medical working in these camps are following things up. And the awareness campaign have been run in all these camps with the European Union through MEDED program. And about personal hygiene PPE were delivered to the residents of the camps for the Syrian refugee in the northern of Iraq and in Iraq for the IDPs who are still now after isolation. But so far so good. Till now, no case was reported in them. Maybe because most of the cases that came to Iraq was mostly of people who have visited neighboring countries that have been infected, mostly the Republic of Iran. So far, contacting cases is not there in Iraq so far. I don't know about the rest of the Middle East, but we have with the Federation of the Red Cross Red Crescent, we have a group that until now we are meeting on weekly basis regarding the cases, and none of them have witnessed any case in any of the camp with the Syrian refugees so far. But all of them are on high alert and running awareness programs for all the residents of the camps in that regard. Thank you.
Thank you so much, Dr. Rashid. It's really great to hear your voice, and thanks for giving us your input and update. I'm going to pass back now to Dr. Kerry's feed because we'd like to hear what her conversation with Dr. Kajambura has been.
Okay, I don't know if you want to turn the video on. I had a brief conversation with the doctor to talk about to get some sense of what Uganda's preparedness is. So what they've done is as I mentioned, they categorized the various countries, and I'm just giving the report quickly, Dr. Kajambula. So they've categorized countries into 3 tiers. There are 16 countries in category 1, which are considered high-risk countries, and travelers from those countries are being asked to self-quarantine for 14 days upon arrival, and they're being discouraged to even travel to the country in the first place. Category 2 are being monitored for 14 days. These are patients who come from countries where there is a low level of the disease at this point. And then Category 3 is where there is no COVID, but they will be screened at the border. There's been robust screening at the one international airport in the country in Entebbe, as well as screenings at the various borders in order to really try to monitor for signs and symptoms. There is a national virology lab that is capable of doing testing using the PCR testing, and they actually have a national referral system that can transport specimens to the lab. They've so far conducted 26 tests, all of which have come out negative. And that's the overall report. I think if there are specific questions that people would like to ask, please feel free to chat them, and I can ask Dr. Kajambula and then come back and give you his responses.
Thank you so much, Dr. Kerry.
I just need
really
the
appreciate
support for you.
Thank you very much. Really appreciate that. We had a question specifically about the nursing workforce and how to ensure the nursing workforce is prepared. So we've asked our colleague, Dr. Sorry, she's laughing. Not Dr. Mary Siebert, who's the Director of Global Nursing at Mass General Hospital, to join us. She's sitting beside me to talk about that.
Hello, everyone. So the question was that nurses provide most primary care on the front line in the resource-limited settings. How can education and essential support be provided for nursing partners? Right now, I think that between Seed Global Health and the Center for Global Health, we're limited in what we can actually provide at this time due to the virus. We've had to cancel our nursing fellowships. We've had to limit people being able to go over there to teach them. However, we can still use WhatsApp, use the various different modalities to communicate with them. And that's what we've been doing because they have a clear understanding that we cannot come to Uganda to teach, or to Tanzania, or see Global Health, who's in Malawi. So we just have to provide the support best we can at this time until we are cleared to provide our nursing education support once again, which is our primary responsibility with Uganda.
And Mary, we talk a lot in our group about empowering the voice of nurses, given that we know nurses are providing so much of frontline care. Is this the moment to also rally the nursing workforce to ensure that they have a voice in being prepared and getting the education they feel they need and the protections they need in terms of PPE?
The protections, and it's difficult, as you know, the Uganda minister probably knows. However, in Mbarara, we had a critical care program, and so right now I think they are the kind of the leaders in the critical care education out there, and they're around the country in the different ICUs and the different facilities. So I think that they're our best advocates out there for taking care of these critical patients, and thank God we've had about 30 of them that are spread out through the country right now.
Great, thanks Mary, especially for talking there about our particular partnership in Uganda and our experience in educational exchange in Uganda in ICU care. I wanted to bring one question back to Dr. Rashid, if you're there. We had a question about how we can serve humanitarian commitment, maybe as individuals or as organizations, that often requires a lot of global movement and travel. Are you thinking of screening incoming humanitarian workers? Are there approaches we should be thinking about or advocating for? How do we make sure that global movement of development and humanitarian workers doesn't introduce the virus in places where we don't have it or worsen its spread?
Oh, okay. Now, the issue is regarding the humanitarian workers. It's a really challenging situation right now for not only for their work, but for their own safety. So this is the issue. Screening, so far, many of the countries couldn't do it apart from temperature, because it's very expensive with restrictions, and especially that it is outbreak that changed into pandemic came so sudden that nobody was prepared to it with such an advanced situation, and the world is facing many crises all over the universe, between migrants, refugees, IDPs, and beside the many below poverty line communities. So what we are now trying as much as we can is that we are trying to find volunteers who are with a good health, examined by medical services, but we cannot screen all have a corona. But what is helping now is that all these volunteers who are working in an environment or in touch with the people who need certain services are all being protected very, very well in different grades. For instance, if we are talking about just awareness, they are giving them a PPE of grade 1. If they are working as a first aiders or giving medical services, they are protected. So by this way, they are protecting them. And in the same time, they are protecting the people who are receiving the service. And for instance, now we are looking for instance, the Lebanese Red Cross is working on evacuating the people with the coronavirus into the hospitals. And they take all the measures to save the access for their staff and for keeping the patients or the people who are in service safe as much as possible from even their staff. So it's a two-way challenge. It's not easy, but everybody's trying to work on it. I hope I answered the question.
Yeah, thanks, Dr. Rashid. I think these are all difficult questions without, we don't have all the answers, but we really appreciate hearing from you. I want to go back to Dr. Walton with a couple of questions. One is about, because they're related, one is about how to set up effective isolation procedures in tented areas or in very rural clinics. And I think related to that question is the challenges we have in access to PCR testing and some of the innovations coming down the line around use of immunoassay more broadly. So I'm going to pass over to Dr. Walton.
Thanks very much, Dr. Ivers. And so let me address the first question first, because it's actually pretty straightforward. Because when you're talking about isolation tents, you're working under the assumption, or I'm working on the assumption, that you have been able to segregate cases either with a clinical tool or what have you to an isolated area of your campus. And that makes a lot of sense, and I think that's what we're really recommending as well. So we've been thinking about this a lot, and again, we're taking lessons from previous sort of epidemics, or cholera, Ebola, and particularly given that this is airborne, there are recommendations around sort of the isolation tents. If you have an isolation room, obviously that's ideal. If you have negative pressure, that's also ideal. If you don't have negative pressure, it's fine. If you do have an isolation room without negative pressure, but just regular air, as long as the door is closed, again, that's all sort of pie in the sky for many of you out there. I think pragmatically, if you have a tent, you can create very basic tents with, or fancy, whatever your sort of your resources are. But if we take a sort of a extremely limited resource view and say we can create spaces with sort of plastic sheeting and 2x4s and a steady roof and protecting people from rain, obviously the healthcare workers need to wear the appropriate PPE, as I talked about earlier, but particularly around the setup. Dr. Lai had mentioned that ideally, but conditions can be challenging, patients will be 6 feet apart, their beds will be 6 feet apart. And the ventilation or just sort of airflow actually can be natural ventilation. And in fact, that's what's been done in the past in prior epidemics. If you have access to negative flow in terms of exhaust fans and louvers from a tent perspective, which can be done, that's nice, but again, not absolutely necessary. But making sure you have appropriate natural ventilation through the tented area to protect both patients and healthcare workers, and making sure that the beds are, in an ideal world, 2 meters or 6 feet apart. Now, the second question around testing is a bit tricky. So let's go through testing as it stands right now. Right now, the sort of gold standard is the RT-PCR. Very few labs can actually do that in resource-constrained settings, and so that's obviously an Achilles heel for many of you out there, for your ability to actually diagnose cases in a quick way. There is a immunoassay out there. It's being, I think, manufactured in China and was used by the China CDC in order to sort of be an adjunct to their case detection and surveillance. Now, here's the tricky part with the immunoassay. There's a paper that accompanies the immunoassay. Sensitivity and specificity are not 100%. They're sort of in the 80s. And so if you're using that as a diagnostic tool, you're going under with the assumption that you're going to get some of your positive cases will be negative and some of your negative cases will be positive. And that's a really challenging situation. The other alternative currently, if without the RT-PCR, as a clinical tool that has yet to be developed, that's also tricky. So there isn't a perfect answer out there. But the thing about the immunoassay is the lag time, right? Your immunoassay is looking for IgG and IgM. But there isn't great data to suggest what the lag time is between introduction of the virus into the host and the development of IgG antibodies. Therefore, you know, what some people are considering that are going to potentially use the immunoassay is using a sort of a suspect ward. So you segregate the patient because you think they have pulmonary symptoms or what have you, and then they're in a suspect ward, and you're holding them there, again, very dangerous for nosocomial spread, but you're testing at times 0, times 24 hours, and times 48 hours, thinking that there may be a 3-day lag time in terms of their ability to mount an immune response that's detectable by the immunoassay, sort of understanding the limitations in sensitivity and specificity. So that's a really tough situation. There isn't a perfect answer out there, but some are procuring the immunoassay now to be able to add into their armamentarium for diagnostics. And then finally, there isn't, outside of RT-PCR, there isn't clear, readily accessible antigen testing. We do know that the gene experts, they are actually actively working towards antigen testing currently. It's a few months out. For those of you who do have access to gene experts, which are, I'm assuming many of you in the field dealing with TB, that is coming down the pike. But it's, you know, they've announced it and they're working on it, but it's really unclear when that's coming. That obviously would be a great, depending on the sensitivity and specificity, a great gold standard for true diagnostic purposes in real time, but that remains to be seen.
Thank you very much, Dr. Walton, for that. We are almost close to the end of time, but we're not finished yet, so don't sign off. I do want to say, just before we get to our last question, in case you have to drop off early, that we have had an overwhelming interest in this panel. We had way more than 100 participants. We weren't quite expecting that. We're planning again to hold another session next Friday. We will have greater capacity next Friday, so please tell your friends they can come. We'll be able to host 500 people next time. I want to ask Dr. Maxi Raymonville a question that's been posed to us. If you can hear us, Maxi, and can answer, great. I see you. Workforce, we know that people over 60 years of age and those over 50, but especially over 60, are really vulnerable in this epidemic. Have you thought about trying to have any strategies for volunteers who are in the younger age groups? Have you excused any of our older workforce? Is there any way to handle that? If you could briefly comment, that would be great.
Here's the situation right now. We are planning, to use, in the Mirebalais, but not for the MSP in general. The staff that we're using, they are really young, but most of them, they are working at the treatment cholera center. And if you're looking at the staff who really can handle with this type of critical care, you have a staff really well trained at the emergency department. And some of them, they are resident in training. And if you look at the situation at our critical care unit, you have a group of nurses really well trained, not only for adult patients, but a few nurses in the Mirebalais has been trained for the NICU, neonatal intensive care unit. And one of the things I keep thinking about, how maybe some of these nurses really well trained for the NICU, how you will need to reinforce them in terms of training and to address, adult critical care patients. And then that's the type of mixed staffing things, how to reinforce the level of training for the nurses you used to work at the cholera center, but not really having enough tools in terms of critical care patient. If you have to put some of patients who really need ventilation type things of that. But again, it's really challenging, how to manage, in terms of staffing right now in this context.
Yeah. Thanks, Dr. Raymonville. So as we come to a close of the session, we're going to share with you again our website and our Twitter handle so that you can follow to get information for what we hope to do next week. You can feel free to send us suggestions on what you want to hear about. We had some questions we weren't able to get to. I think many of the questions we're talking about today, by next Friday, we'll actually have new science, we'll have new information, we'll have new experience. I want to acknowledge the fact that when we think about global health, certainly at Mass General Centre for Global Health, we're thinking about health equity, and we think about how there are many vulnerable communities even in resource-rich countries. So many of those communities are facing similar challenges. We know rural healthcare in the United States is very limited health workforce. So we're not specifically addressing those questions on this panel, but we hear you, and many of us here in this room are actively engaged also at home trying to address those. So I'm going to wrap it up here. Thank you everyone so much for joining us. Please stay tuned and submit questions for next time. We'll share with you ways to do that. We appreciate our panelists. Apologize to Uganda for the challenge, but it was great to hear from you, and take care everyone, and we'll be in touch. Thank you.